All right, so we're continuing. I went through the low flow devices as far as your nasal cannula and transtracheal catheter. We talked about the reservoir systems, the mustache reservoir and the pendant reservoir, those very attractive looking devices. Now we'll move on to our what Egan classifies as reservoir oxygen devices. The first one of which is called just a simple oxygen mask because it's awful darn simple. A couple of features on it that it has, some exhalation ports that they can exhale and inhale through. There's a flow of oxygen that basically is just coming into this cone, which is sitting on top of the patient's face. There's an elastic strap, and there's a malleable metal nose piece that allows for the mask to be fitted to the patient's face as need be. So here's an example of one that we end up having. So the patient would just place this on their face and wrap the strap back behind their head. Okay, and then we would hook this up to our oxygen flow meter. One hospital I worked at was in one area of the hospital. They had a very sophisticated method. They would take a styrofoam cup, poke a hole in the bottom of it, run an O2 tubing to it, and have the patient hold it over their face, and that was a simple mask. And in essence, that's exactly what it did. The proper flow rate range for a simple mask is 5 to 10 liters per minute. The key part there is we don't put it anything less than 5. And the reason being is it won't flush out any carbon dioxide that builds up inside the mask. So minimal flow, 5 liters. Usually don't need anything much more than 10. The range of oxygen we're going to use for a simple mask is 40 to 60. Egan gives a little bit of a different value. I'll explain why I use 40 to 60 in a bit. It's just easier to remember. Again, it is a variable FiO2, so this is not considered a high flow system. All of the reservoir style devices are considered to be not high flow, even though the flow rate of 10 liters per minute seems like a lot. We use it in emergency situations for short-term therapy. And just basically, I need more than what a nasal cannula is going to give me. This will allow me to give a little bit more. Some of the advantages, it can be used in both adults and down to infants, so it's a wide range of uses as far as patient size. Must use the appropriate size mask, obviously. As you saw, it's quick and easy to apply. It's disposable and inexpensive, but the downside is they're uncomfortable, especially for patients that have some claustrophobia. That mask can freak them out a little bit. You also must remove the mask to eat, so it kind of breaks up the high oxygen levels that you're generating. And another big problem is if the patient accidentally vomits into the mask, it can become an obstruction where it won't deliver the oxygen flow. You can use it with a humidifier. Because of the patient saying it's dry, or if the physician requests that we have a added humidity there. Partial rebreather mask is designed so it looks like a simple mask on top. However, now I end up having this reservoir bag that has been added. On inhalation, oxygen is filling not only the mask like it did in the simple mask, but it's also filling this reservoir bag. On exhalation, then when the patient exhales, they exhale the first part of their breath back into the bag. Subsequent breaths, then they're partially rebreathing that gas. What they're breathing back into the bag, though, is thus their dead space. So there's no carbon dioxide in the dead space gas because it hasn't come in contact with the gas exchange units. So it ends up a problem. Okay. So a partial rebreather looks like this. And again, it has open holes that the patient can inhale through, so as they're drawing in the gas from the bag and the mask, they're also drawing in from the side. So there's some air that's being entrained as they take a breath in. And then they're also hook this up so I can show what we need to do.
Why do you need the patient to rebreathe on that?
We don't need them to, they just do.
And
Because this part of the dead space gas has a high concentration of oxygen, so when they exhale it back out, it adds to whatever is there. The key part to remember is twofold. One, I want to prime the system. Since this bag is deflated, I want to go ahead and add some flow. Put my finger over the opening and allow the bag to fill so it's always filled to start with. Then when I attach it to the patient, as they draw, this bag should never go more than halfway empty. So if I'm seeing something like this, it means I don't have enough flow. Okay, you want enough flow to keep the bag half full at all times, or half empty if you're a pessimist, I guess, I don't know. Partial rebreather. Minimum flow rate you want to start with is 10, and we're going to add additional flow if it's necessary to keep that bag half inflated during inspiration. So you never want it to completely collapse. RFiO2 range is going to be 60 to 80. You can see the nice simpleness here, 40 to 60 for a simple, 60 to 80 for a partial. Although Egan says it's a little bit lower than that. Again, it's a reservoir device. It has ports through which the patient can breathe air in. So the FiO2 is not guaranteed. It's a variable range. And we use it when simple mask isn't doing enough. We want a little bit more. Okay, so it's another addition there. So not only is oxygen collecting in the reservoir bag and in the mask and in their oral pharynx, they're getting more than they would with a simple. Same kind of advantages, same kind of disadvantages. So really they're true for pretty much all the masks involved. Moving on then to our last reservoir style device, where it's a non-rebreather mask. And the non-rebreather is a little bit different in that it has a valve between the mask and the bag itself and a valve on the side of the mask, looking like this. So same kind of idea when I want to add flow to this. I'm going to go ahead and put my finger over the valve and fill up the bag. Put it on the patient. When they take a breath in, they can only get air or oxygen from here as well as what's inside the mask. They can't draw them in from the outside. Then when they exhale, it only can go back out through the valves on the side and not back into the bag because there's a valve blocking that. Okay, non-rebreather. Now, clinically, we use it like it's shown up there. Right now, there's two valves on the mask on the side. We're going to remove one of those valves. It allows for air to be entrained, so we're sacrificing a little bit there. But if I have both valves on and I lose flow, patient asphyxiates because they won't be able to get any air. Not a good idea. So clinically what we do is we remove one of those valves. And when you come in for your PE, if you're setting up this device, we'll expect you to know that you're supposed to remove that second valve. Okay. So again, non-rebreather mask, same kind of idea, 10 liters per minute. Don't let the bag completely collapse on inspiration. Should always be half full. Our FiO2 range is, well, how about 80 to 100? It's in a dream, but you'll never get to 100. But it's, like I said, Egan says about a little bit of a different value. Again, it's variable FiO2 unless you have all the valves on and that mask is tightly fit and we're getting 100%. It's a variable FiO2. Highest you can do for the most part as far as masks are concerned without intubating the patient. And we would use it for emergency. So somebody coming in with congestive heart failure or a trauma patient, we may put them on a non-rebreather. It also can be used for delivery of some of our specialty gases, one of which you've already been familiar with, Heliox. We use Heliox for patients with high airway resistance issues. say a status asthmaticus, that we want to be able to have gas delivery occurring. A low dense gas like heliox will get in better than oxygen will. And carbogen is a combination of carbon dioxide and oxygen. And we would use that for a couple different reasons. One is hiccups. Somebody who has such profound hiccups that they can't stop hiccuping and it's interfering with their ability to eat and sleep and everything else. How do you guys cure hiccups yourselves?
Hold your breath.
You hold your breath, right? What do? You build up CO2. So what we're doing here is we're administering CO2 and driving their PCO2 up with the hopes of stopping that process. The other reason we use carbogen is higher levels of CO2 have the ability to increase perfusion to the ear and to the eye. So if somebody comes in with sudden vision loss or visual disturbances, or comes in with acute hearing loss, carbogen is indicated in that case. So there's a couple of different reasons that we may end up seeing it. Same advantages, same disadvantages. The only thing we don't do is use a non-rebreather with children. I know they're kind of funny. They like to take small pieces of anything and put it in their mouth and inhale it. So those valves, because they can be taken off, you got to use caution in that case, and typically we don't want to end up using that. So again, partial has no valves, non-rebreather has the valves. Okay. A couple of other masks that might be there that we might use for the patient or for us. If a patient comes in, let's say, with tuberculosis and we need to transport them outside of their room, we can use one of these style of masks that are either, it's a simple mask. On the right-hand side, you can see there's just a simple mask with these specialized filters on, or a non-rebreather with those specialized filters on, covering up those expiratory ports or inhalation ports that are there.
Are those the same as HIPAA masks?
No. No, you're thinking of the N95 mask that we would use for TB. No, they're different. These are more for if the patient's being transported, because it isolates all their exhaled gas into a filter and filters it out. That's all it does. Nice little summary for you that you may want to focus on, just saying. Are the flow rates of all the reservoir systems higher than the low flow systems flows? Yeah. I mean, the lowest flow you would end up seeing is 5 liters per minute on a simple mask. So any of the other reservoirs are much higher than a nasal cannula would provide. Do all the reservoir systems flow meet the patient's entire inspiratory flow? No. Okay, so they're not classified as a high flow device, even though I'm using 12 or 15 liters per minute. Are the concentrations delivered by the reservoir systems higher than the low flow systems concentrations? And most definitely they are. Okay, that's why we're using them. We want to get a higher oxygen inspired concentration. I can do it with a simple partial non-rebreather mask than I can with a nasal cannula. And are the FiO2s of the reservoir systems fixed or variable? And they're variable, again, because the total flow is not being met. By definition, a high flow system provides enough flow to meet or exceed the patient's inspiratory demands. What's wrong with this picture? Where is the float on the flow meter? Looks like a couple liters per minute, and they're on a non-rebreather or a partial breather. So flow is way too low, and the bag looks like it's flat. So some of the problems, if it's hot and uncomfortable, sometimes just turning up the flow will help out a little bit. Okay, a little more coolness. Irritation, we can use as any kind of some cotton balls or something to alleviate the pressure sites. Need to remove to eat, we're going to need to provide a nasal cannula during meal times. Traps vomit with potential for aspiration, got to monitor the patient and keep them in an upright position. And potential suffocation if O2 flow was lost or the valves stick. And again, monitoring them, and we remove one of those valves on the non-rebreather for safety purposes. Breathing pattern affects the oxygen delivery. And again, this monitoring the patient. Reservoir bag collapses on inspiration. We know we got to turn up the flow. And any obstruction, we want to relieve it, and especially making sure the tubing isn't getting run over by the bed rail or something else. So those are my low flow or reservoir devices. All have variable FiO2. Now we'll move into the high flow devices. And these are the last two, high flow and enclosures. I should throw that in also. And they're divided into one of two groups, one where we end up having an air entrainment system of some kind to generate a total flow that's in excess of what the patient does, or we have a gas blending system where we're using a blender to mix the two, and we'll talk about each of them. Let's start off with our high flow nasal cannula. There's a couple different examples here. There's the device is called an OptiFlow, and that's this device I have up here in the front of the room, and I'll talk about that in a second. We also have one that's called a Vapotherm, which is in the back over there. And there's also a third one we just bought called the Arvo that I don't know where Amber hid it, so I have to find it. This is what the OptiFlow nasal cannula looks like. It's a flexible nasal cannula that allows for a heated, humidified concentration of oxygen to be delivered. We're typically starting on somewhere on the order of 30 to 40 liters per minute. So it's a very, very high flow device. If I were to put 30 to 40 liters through a traditional nasal cannula, it would dry the nose out in no time at all. Because I'm heating and humidifying it, it's much, much better tolerated. Probably don't want to go much over 60 liters on a conventional circuit, and you can dial in your oxygen percentage to get to 100%. And it can be used with an endotracheal tube as an invasive mechanism also, so that I can truly get 100% relative humidity at 37 degrees Celsius. One of these devices that we're going to use that we have here is called a Downs flow generator. Downs flow generator. John Downs. And the way this device works is we hook it up to a 50 psi oxygen source, so it plugs into the wall. From there, then it comes into our blender component. That's what this part is here. It's going to entrain some room air through here, and it's going to blend it, mix it with some oxygen coming from my source. We use this filter on there, filter the gas for one, but also to shut it up. It's loud. Okay. There's two controls on the side. One sets oxygen, so we turn this to get to the desired FiO2. So if I want 60%, I turn this until my oxygen analyzer, which is what this is, reads 60%. Now for our PE, we won't be able to do that because we have air and we have air that are being blended. But you get the gist. The second control is the flow control that I would adjust to the desired flow. So say I want it at 40 liters per minute. I have my flow meter right here on front. I can go ahead and set that to 40 liters per minute. And I have 40 liters per minute of whatever FiO2 I have desired. I can go anywhere from 21 to 100%. It then continues on to my heated humidifier. And this is a pretty standard heated humidifier. This canister slides out, and this is just basically a hot plate. This has got a metal bottom, so it's going to warm that any water in there up to whatever our desired temperature is. Then it has between the humidifier and here, it has a small wire that's running through. I measure the temp here, I measure the temp here, and it's going to keep it constant. What happens when warm, moist air leaves this site and travels through room temperature is it's going to condense out, right? By keeping this all warm at the same temperature as we have here, I don't have any water accumulation. The last step then is it attaches to my nasal cannula. The nasal cannula has two lanyards, one that goes around the patient's head to attach the prongs to their nose. That's pretty rich. The other one goes around their neck, and basically if this drops down, it doesn't allow it to fall on the floor. Okay? So that is a high-flow nasal cannula using the OptiFlow. It's one of the three devices we have. Say that? Say again? Why would I use this? Because I want a high concentration of oxygen guaranteed.
High concentration of oxygen.
Guaranteed. So if I want somebody on 60% or 70%, I can't do with any other of my devices on a fixed basis. I can now, because the inspiratory flow is high enough that I'm meeting or exceeding the patient's demands. Truly a high flow system. And he looks happy, right? So again, what we end up having here, letter A is my oxygen sensor that is attached to my oxygen analyzer. I have my flow of gas coming in from this green hose and air being entrained through this filter. There's an O2 percentage and a flow rate control. And when you look at it, you can end up seeing those two controls there. It then passes out through my humidifier and onto the patient. And my Fisher-Paykel humidifier, heated humidifier. There's an infant one also. The only difference between them is that the cannula needs to be sized correctly. The cannula cannot occupy more than 1/2 of the inside of their nostrils, their nares. If it becomes larger than that, it can actually obstruct them from exhaling. One of the things we'll find is that infants are obligate nose breathers. They only breathe in and out through their nose. And if there's an obstruction there, that can lead to some problems. Specifically, a buildup of pressure, creating a CPAP effect, which may not be needed. We also add a safety pop-off on the inside of the circuitry, which is what this part is here. A pressure relief valve that doesn't allow for a large amount of pressure to be accumulated within the circuitry. Just a safety feature. Gas flow is a whole lot less. We're not going to start at our 40 to 50 liters per minute. We're going to start at a much, much smaller flow because their flow needs are less. And I don't expect you to memorize this, but just recognize, again, they have these little handy charts. They're available for you, what the max flow is for various sized children. Bottom line, the maximum flow you would use gets bigger as the kids get bigger. Big duh. Okay, because their needs are higher as they get larger, so our system has to be able to accommodate that. I'm too cheap to buy one of these machines. I want to make one myself. I can do it. I'm a respiratory therapist. Take a blender. The flow meter then regulates the blended oxygen percentage, run it through my heated humidifier, have some tubing going on to the patient. I'm golden. And in the old days, that's what we used to do. Now we have basically entire setups that are utilizing this. I'm really, really cheap. I don't have a blender. So what do? I go ahead and I hook up an airflow meter. I hook up an O2 flow meter. I run them both at some liter flow, and we blend them together through our humidifier and onto my nasal cannula. Okay? What FiO2 am I delivering here with air set at 15 and O2 set at 15? How would I figure that out? What formula? Got my pen. This is one we learned at the very end of 1060 last fall that everybody forgot. Yep. Not the magic box. Does that look vaguely familiar? So 15 plus 15 times 0.21 divided by 30, and if you work it out, it works out to 0.6. O2 flow plus the airflow times 0.21. Why 0.21? Because air has 21% oxygen. Divided by the total flow of both the air and the O2. How do I know it's 60%? It's a 1-to-1 ratio.
I don't even remember this.
Huh? Doesn't ring a bell at all? Olivia's in the fog. I know, it's Lori's test beat you up and you're just... We did talk about it. Or not we. Lori did. So you're going to find that you may want to fish out 1085 when we talk about all the high flow stuff, because it's all coming back now, and now we're going to see how we apply it. Another device we have, the other one there, is called the Vapotherm, and it has an internal cartridge that allows us to go ahead and heat the unit up to get our appropriate FiO2. It's got a blender built in, or get our an appropriate flow and temperature and humidity setting. And they come in two different size cartridges, one for adults, one for pediatrics, and they're basically just less dead space on the inside. But you can see I'm setting my oxygen flow, I'm setting my oxygen percentage, and I'm setting my temperature, and the little baby's sleeping happily. The rest of it is exactly the same. The difference being is that this humidifier and this blender is not there. All I have is this tubing going to the patient, because everything else is built into it. Which one do you use? Whichever one the hospital has. Other uses for high flow nasal cannula, especially in infants, delivery of Heliox, as we mentioned, nitric oxide, or with a vibrating mesh nebulizer called Aerogen, you can end up actually delivering medication nebulized. All right, let's venture back through air entrainment masks. And I know we again covered this before, but I know for a fact it was never. Don't look at me in that tone of voice. Couple different designs that are there, and they either, if you'll notice, this air entrainment window on all of these are the same size. What changes is the jet orifice size. Here I have two adapters that have different size jet orifice size, but I also changed the size of the entrainment window. And I'll get some examples of these so you can play with them and get a feel for them. So we're going to need our oxygen source. We're going to need a flow meter, obviously, to control the flow, and a nipple adapter to attach the O2 tubing to the mask itself. And then we need to figure out how it determines what concentration of oxygen is needed. And rarely do we need humidifiers because the amount of air you're drawing in is so high. Here I have, again, that jet. Oops. And this is my air entrainment window. So either one of the two are going to be altered to change my FiO2. And if I would change, let's say I'm on 24% and I want to go to 28%, I just swap out the adapter. Or in this one, I just turn this and change the size of the window. There is also this collar, looks like this, that serves another purpose. One, it has a opening where I can attach a small volume nebulizer to. So if I want to give a breathing treatment, I don't have to take the mask off. I can just hook it directly up and deliver the treatment. The other thing it does is it protects that air entrainment window from becoming obstructed by the blanket, by the guy's hand holding it. Because if you do that, you're changing the FiO2. So that prevents it. Again, the flow rate that we're using off the wall will vary depending upon manufacturer, but it'll tell you right on the device what FiO2 you need. For a given FiO2, what flow rate you need to set the patient at. So let me pick on Olivia here. In order to generate 3 liters per minute, 24%, what liter flow do I need?
If you need what?
To set 24%, we need 3 liters per minute. So all it is just basically looking on the mask, and it'll tell you what liter flow it is. There's another piece missing here. Okay, but it tells us right on the mask what liter flow we need. You can check those out later. The FiO2 range is precise, and it's anywhere from 24% up to 50%. When you get above 50%, you lose accuracy because the total flow is not sufficient. So the most you'll ever see is 50% on these devices. When do we want to use these? We want to use them in patients where we want a controlled, fixed FiO2 and we don't want to have any variability. An example of that is a patient with chronic carbon dioxide retention, our COPD patients that have elevated PCO2s. The way that they breathe is a little bit different than you and I, obviously. You and I breathe based upon carbon dioxide levels rising, and our bloodstream stimulates the floor of the fourth ventricle, and the medulla oblongata is vaguely coming back. Oh no, oh no. But basically when our CO2 levels rise, we get a trigger to go ahead and take a breath in. It then falls and then gradually rises back up. We take a breath in. COPD patients with chronic hypercarbia don't breathe like that. Now, you'll hear the term hypoxic drive used, that they breathe based upon becoming hypoxemic. It's not really true. They breathe under a different way. The bottom line is that excessive oxygen therapy, driving their PaO2 higher than we need to, can actually lead to hypoventilation. And it's called, novelly enough, oxygen-induced hypoventilation. So those patients with who have our CO2 retainers, we want to be cautious about driving their oxygen levels up. Give you an example. I had a patient, she was long-standing COPD, one of our frequent flyers. She was in for some diagnostic testing. They took her down to endoscopy or something, and she was on a 2-liter nasal cannula. Okay. Nurse called me because she wasn't arousable and wanted to get a blood gas on her. I did the blood gas, poked her, she didn't even move, so I knew, I'm good, but got her PCO2 back, her PCO2 was 120. Slightly elevated, right? Her PO2 was like 110. So what ended up happening is they went down for this procedure, gave her some Valium. That suppressed her respiratory drive. She hypoventilated. Because on a nasal cannula, as ventilation goes down, oxygen concentration goes up. So remember, we're entraining less room air as we hypoventilate. So on a low-flow device, the FiO2 will get higher. So every breath she took, she was getting a little bit higher oxygen concentration, which drove her PO2 up, which caused her to have the oxygen-induced hypoventilation. Net effect, she had a PCO2 of 120. Yikes. Got everybody's shorts in a wad for a little while. Had she been on a Veni mask or air entrainment mask, that wouldn't have happened, or if it did, it wouldn't have been as severe. So just a simple selection of oxygen devices makes a huge amount of difference. Again, the advantages, the biggest one is it's a precise FiO2. The other ones, yeah, they're easy to apply, it's disposable, it's inexpensive, blah, 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 blah. Disadvantages, like the other ones, it can be uncomfortable for somebody who's claustrophobic. They can be a little bit noisy, especially at low FiO2s, because I'm entraining so much room air. Like any other mask, it must be removed for eating. And one unique thing, and put a star by this one, because we're going to talk about this again, any air entrainment device that had... Any air entrainment device that we have, whether it be these air entrainment masks or whether it be the air entrainment nebulizers we're going to talk about later, any downstream back pressure, any downstream obstruction will cause the oxygen percentage to rise. So I said, if I set it up on 40%, it's always going to be 40%. Well, there is one exception to that rule, and that's if I have obstruction downstream from it. That back pressure will actually cause the oxygen percentage to rise, and I'll explain why in a minute. All right, back to 1085. Please no, put a needle in my eye. This mechanism of fluid entrainment, air entrainment, is how both nebulizers and the air entrainment masks work. And what they do is they have one flow of gas that is passing through, in this case 100% oxygen, and it causes a secondary a secondary fluid to be drawn in, either air or it could actually be a liquid in the process. This is based upon something called the Bernoulli effect, which I know you may have seen that name at some point, but I've forgotten totally about it. So we'll talk about it again. And there's actually something when we use a device called a Venturi tube that I can not only mix these two gases, I can also draw up a secondary liquid. They're based upon the concept of a cross-sectional area being decreased and therefore the forward velocity being increased. Now let me speak to this in English. Remember we talked about a hose. Maybe we didn't. But if you have a hose that has a certain flow of water through it, I pinch the end of the hose, which now reduces the cross-sectional area. That also causes that fluid that's coming out of there to have a higher forward velocity. It goes further, right? You guys have all played that trick with a hose, and if not, then go home and do it. Well, it's kind of bad being winter and all, but you get the idea. Velocity, remember, is the distance traveled per amount of time. And in this case, what you end up seeing is the cross-sectional area decreases, the forward velocity increases. Cross-sectional area increases, forward velocity decreases. So they're opposite of each other. It's called the law of continuity. Let's take a look how these are applied. First one, as the pressure, or because there's a stopper here, the pressure remains constant across all those tubes. Once I open it up and allow gas flow to occur, the pressure is going to drop. Well, yeah, it has to. Flow cannot occur if there's a constant pressure. It's got to be from a higher pressure to a lower pressure. Make sense so far? Let's add in a restriction. Now what ends up happening is, as that point comes, the constriction causes the cross-sectional area to reduce, the forward velocity to increase, but it also causes a localized drop in pressure. So it actually creates a vacuum, as we'll find. More on that in a sec. And here's the sec. So here I have this flow going by. As the fluid is moving by, it's actually entraining air. it's sucking air in, or if I had this inverted, it can actually draw fluid up into it. And we'll see where that plays in a bit. But that's Bernoulli's theorem. A flowing fluid's lateral pressure must vary inversely with its velocity. So the wall pressure is going to decrease as the forward velocity increases. That's what creates the vacuum at that point where the tubing narrows. And again, we said this was the law of continuity. Velocity of a fluid moving through a tube at a constant flow varies inversely with the available cross-sectional area. We had some examples talking about the pinching of a garden hose or a nozzle on a spray bottle. We're changing the cross-sectional area, therefore changing the forward velocity. That's what these devices do. Okay. They change either the jet size to accommodate a faster forward velocity, or they'll change the window in a second. So here the area of constriction is changed. So I end up having a pressure drop across, and I can get very high as I make that very, very narrow. So different cross-sectional area causing a different forward velocity, but then also causing a drop in pressure on the wall. Where do we see this? Well, we see it in our bodies, our tracheobronchial tree. As the airways get narrower, the cross-sectional area actually increases. Well, if the cross-sectional area increases, that must mean that the forward velocity goes down, which is what we get as we get to the more peripheral airways. They're smaller in nature, but there's also more of them. We end up having more laminar flow. So you may have seen this slide from last year. Constant 5 liters per minute of flow going through, but the initial forward velocity changes as we change the cross-sectional area. Now the flow is not uniform throughout the tube. The flow has what we're going to call a parabolic shape, meaning at the center of that tube, the flow is the highest, and as it goes towards the wall, it slows down because of frictional resistance. This vaguely coming back? You liar. Okay, we call those streamlines. But you can see the parabolic shape. You know what a parabola is, right? Something that looks like that, right? X squared, there you go. So here I have my gas flow, my main gas flow of oxygen, powering this device, driving that flow of oxygen through a jet orifice that has a variable size, but it's less than where we started, so it's a loss of cross-sectional area, causes the forward velocity to increase, causes the lateral wall pressure to decrease, and for air to be entrained. But it does it on a fixed basis. Depending upon the size of the jet, depending upon the size of the entrainment window, I can get a precise amount of air being entrained. So I have a certain ratio, a 3-to-1 ratio delivering 40%, a 1-to-1 ratio delivering 60%. Smaller jet openings cause an increase in forward velocity, which allows for more air to be entrained, and FiO2 goes down. The total flow, on the other hand, does go up. And the opposite would be true with the larger ports. FiO2 decreases because less with a larger port, you end up having more air being entrained and FiO2 going down. Opposite is true if they're smaller. Vaguely look familiar? Okay. Do we ever want to memorize this? Hell no. How do I fix it? I do the magic box. Or the 100 minus 20, 20 minus the FiO, or FiO2 minus 20, 100 minus the FiO2. So we either are going to change the jet size or the port size to get our specific FiO2. The O2 flow is always constant. What we're changing is either of those two parameters and allowing us to entrain more or entrain less oxygen. Going through and narrowing, cross-sectional area goes down, forward velocity goes up, lateral wall pressure drops, and training some gas into the flow. And it does it on a precise basis. So that's our basic design. I can either change the size of the entrainment port or the size of the jet. Which one doesn't matter. Some masks do it one way, some masks do it another way. Both of them accomplish the same thing. Is this ringing somewhat of a bell? So, oh boy. Let's go through these. I decrease the size of the jet, what's going to happen to the flow coming out of the device? Well, it's going to go up. Decreasing the size of the jet causes forward velocity to go up, more air is entrained, total flow goes up. What about if I increase the size of the jet? Cross-sectional area goes up, forward velocity goes down, less is entrained. Total flow goes down. Decrease the size of the ports, less is going to be entrained, total flow goes down. Opposite is true when I make the ports bigger. If I decrease the oxygen flow, well, the starting point goes down, so the overall total flow is going to go down. Increase, the opposite happens. Pinch the oxygen hose, I'm going to have less flow going to, so less flow is going to come out. And the same would be true with an aerosol when we talk about nebulizers. How about the FiO2? What's going on there? Decrease the size of the jet, increase forward velocity, entrain more air, dilute that oxygen down so my FiO2 falls. Opposite is I make the jet bigger. Decrease the size of the ports, means less air is being entrained, so the FiO2 goes up. Opposite with an increase in size of the ports. Interesting thing, what happens if I change the flow? Nothing. Oxygen flow meter setting does nothing. Just warning you. Up or down, doesn't matter. Total flow will change, but not the concentration. When I pinch the aerosol hose, or if I create downstream back pressure, we talked about that causing the FiO2 to rise. Pinching the oxygen hose doesn't do anything. Reduces total flow, but doesn't do anything as far as the oxygen concentration. I'm going to skip that one. I think that's where we'll end it because you guys look beat. And I'm beat. And these kids are going to get beat. There's no camping. I guess they didn't listen. Hold on a sec.